Hello all, and welcome to another edition of the Vertical Integration Program, specifically designed for the medical students. Today's topic of discussion is obstructive airway disease, and for this discussion we have a very eminent panel of faculty members with us. Let me introduce the faculty members for you. We have Dr. Lalitambika Madam, who is a faculty from the Department of Physiology, Dr. Princy Madam from the Department of Pharmacology, Dr. Namita from General Medicine, and Dr. Nitya from the Department of Respiratory Medicine. Let us start off the discussion with a question to physiology. Madam, can you brief us on the normal physiology of respiration to start with?
Actually, respiration, we all know it's a process of exchange of gases, oxygen and carbon dioxide at the level of the lungs, and then it is transported through the blood, and there is an exchange again at the level of the tissues. There are four processes occurring in respiration. One is what is called pulmonary ventilation, where the exchange occurs between the atmosphere and the lungs. The air is, oxygen is entering into the lungs and carbon dioxide is going into the atmosphere. And the second stage is where the exchange, external respiration it is called. Exchange is occurring between the lungs and the pulmonary capillary blood. So that is external respiration, where the oxygen diffuses through the respiratory membrane into the blood and carbon dioxide diffuses out. Then it is transported, these gases are transported, the oxygen is transported to the tissues, and at the level of the tissues, again, internal respiration takes place. That is the fourth one. Third one is the transport, and fourth process is the diffusion of oxygen into the tissues and the diffusion of carbon dioxide out of the tissues. This is what is actually respiration. And the purpose of this respiration is to maintain the blood PO2, PCO2 and pH at constant level, at the normal range itself. So that is the purpose of respiration. And actually, during normal respiration, the impulses, when they are coming from the higher centers, that is, it is coming from the medulla. When the impulses come from the medulla, there is pulmonary ventilation. That time, there is contraction of the diaphragm and external intercostal muscles. The contribution by the diaphragm is more, 75%. This is during normal respiration. 75% the diaphragm contracts and it increases the vertical diameter of the chest. The external intercostal muscles, they also contribute 25%, and that will increase the anteroposterior as well as the transverse diameter of the chest. When all the diameters of the chest are increasing, what happens is the lung is getting expanded. When the lung is getting expanded, there is intrapulmonary pressure is going down. It goes about -1 millimeter Hg relative to the atmospheric pressure. Normal barometric pressure is 760 millimeter Hg, which we take as 0. So compared to that, it is going to -1. And the intrapleural pressure is always negative. At the beginning of inspiration also, it is -2 to 2.5 only. So what happens is, because of this negative pressure and the difference in the pressure gradient, oxygen can be taken from the atmosphere into the lungs. Right. And at the end of expiration is a passive process. Okay. It is just happening just because of the elastic recoil of the lungs. Mm-hmm. Actually, no work or no energy is expended in expiration. Normal expiration is a very passive process. So elastic recoil is taking place and the muscles which have contracted are relaxing. So what happens here is the intrapulmonary pressure goes to +1 millimeter Hg and the carbon dioxide is able to be expelled out. And the impulse, as I told you, the drive is coming from the medulla. Okay. In the medulla, there are two centers, the dorsal respiratory group of neurons and the VRG, ventral respiratory group of neurons. The dorsal respiratory group of neurons contain inspiratory neurons only, whereas the ventral respiratory group of neurons contains inspiratory as well as expiratory neurons, and they don't take part in normal respiration, because I told you expiration is a passive process. The DRG sends some signals which are called ramp signals. They are called ramp signals, and each cycle of this ramp signal lasts 2 seconds and it stops for 3 seconds. So total cycle is 5 seconds. And this contributes to the respiration. So here what happens is, normally we get 12 cycles. That is why our respiratory rate is 12 per minute. And these impulses, when they come from the medulla, they go to alpha motor neurons and go to the muscles. So that is how the normal process of respiration is taking place. And these are controlled by centers called pneumotaxic center And there is a controversial center called apneustic center. They are not very sure about it. Those are in the ponds.
Okay.
So this pneumotaxic center, what it does is it cuts the RAM signal. Okay. So whenever the pneumotaxic center is stimulated, the rate will increase, but depth of respiration will decrease. Not only that, there are also some chemical factors regulating the respiration. There are peripheral chemoreceptors which respond to changes in PO2 mainly. And there are central chemoreceptors which are responding mainly to the carbon dioxide, PCO2. This carbon dioxide can easily diffuse into the blood-brain barrier. And it will be changed into hydrogen ion and it will act there. So these are the things. And other than this, automatic control is also there. Automatically we can control to a certain extent. But that is from the cortex, motor cortex, directly that impulse is gone. But here, what happens is we have a breath holding time. More than 60 seconds we can't hold our breath. Because what happens, PCO2 increases and this is cut off and this is called breaking point. So this is the process of normal respiration.
Right. Thank you, ma'am. So, ma'am, just in continuation, another important thing is the maintenance of bronchial tone. So can you just elaborate on the factors which are contributing to that?
Bronchial tone is very important. Actually, bronchial tone is one which determines the airway resistance. So normally, when we say in inspiration, the bronchioles, especially the bronchioles, are undergoing a slight increase in the diameter so that the air can easily enter. And during expiration, they are constricting. And this is more in obstructive lung diseases. That is the problem in obstructive lung diseases. But there is a normal amount of tone in these terminal bronchioles because smooth muscle is more in the terminal bronchioles. Smooth muscles are more there and the cartilaginous rings are absent. What are present in the primary bronchi, secondary bronchi, that is absent in the terminal bronchioles. So terminal bronchioles are the one which are offering more resistance when there is a constriction and more it can also dilate. So what is this bronchial tone? This is the tone which is normally present, as I told you. And there are three factors which regulate this. One is the neural factors. Neural means during sympathetic activity, there is bronchodilation. Parasympathetic will cause bronchoconstriction. And chemical factors are there, irritants, certain transmitters, chemical transmitters like leukotrienes, cytokines, and even cold air sometimes can irritate these receptors and cause bronchoconstriction. Then there are certain factors like nitric oxide which can relax, they cause bronchodilation. And nowadays they say VIP, vasoactive intestinal peptide. This is released by non-cholinergic, non-adrenergic fibers. And this causes bronchodilation. And they say that asthmatic patients, this is not seen. That is one of the reasons why they are getting obstruction there, bronchoconstriction more. Then there's a circadian rhythm, which we should not forget. 6 a.m. in the morning, this is maximum. And 6 p.m., it is less. That is the time of bronchodilation. That is why during early morning when we see the asthmatics, their difficulty is more. Respiration difficulty is more in the thing. And as I told you, this we should not forget, it determines airway resistance. And airway resistance is the friction of the molecules and also the friction of the molecules among themselves and with the airways. So this is proportional inversely to the diameter. Directly to the length of the trachea or bronchioles, and also it increases with turbulent flow. The resistance will increase when there is a turbulent flow. So.
Okay. Namita? From a clinical perspective, what are the different types of obstructive airway disease and is there any way to differentiate them?
And thank you, sir. Actually, in general, we can classify obstructive airway diseases. It's a broad spectrum. We have different classification, but I would like to tell that for the clinical aspect, we can just tell bronchial asthma, COPD, and including bronchiectasis and OSA also can be included in the present spectrum. Okay. So coming to the bronchial asthma, the history, it can be childhood variant or an adult onset variant. Right. That can be like I'll be dealing with the adult onset variant. So there are certain risk factors for that. So when a predisposed individual is coming to you with certain symptoms, we can diagnose. The common symptoms are maybe cough, maybe a nocturnal cough that is continuous for more than a week without any signs of infection, and a chest tightness and more of a wheeze. That can be a presentation in a bronchial asthma. So when we take the history, they can be having a family history and all other predisposing factors. On the other contrary, in an like COPD kind of thing, they'll be having a risk factor like a smoking, and that will be the presentation will be like around age, like more than 40 years, with typical presentation of dyspnea, breathlessness, and again cough with sputum. That spectrum is again we can divide it into chronic bronchitis and emphysema. So in chronic bronchitis, there will be sputum production, like there is a definition. And then in emphysema, there also they can have breathlessness. So depending upon that, the like symptomatology we can classify like that, sir.
Perfect. To Principal Madam. Madam, what are the classes of drugs which are used in treatment of obstructive airway diseases?
Yeah. So chronic obstructive airway disease, when we see, we have to take the aim of therapy. When we look at the aim of therapy, we look at a stepwise increase according to the symptoms. Unlike for asthma, where you would be looking at a step-down therapy, approaches step-down. And the basic classes, like if you see asthma, we call it simply as controllers and relievers. So let's start with the drugs commonly used for chronic airway disease. The first class is definitely the bronchodilators.
Okay.
And definitely in the bronchodilators, we know the beta-2 agonists are there. We have the antimuscarinic drugs. We have the third group, that is the methylxanthines, which are commonly prescribed. But also we should also consider that there are aspects that are increasing. So you have leukotriene synthesis inhibitors like xylutone. You have leukotriene and receptor antagonists like Monty and Zafilokaz. You have also many other drugs that are coming in. We have IgE antibodies, monoclonal antibodies like omalizumab, and the newer ones, if you see the newer class of drugs that they advocate according to the GOLD 2024 guidelines would be to use RSV vaccines. Vaccination is advocated. Then there are those that affect the eosinophil infiltration, bemralizumab, dupilumab, and mepolizumab. So these are the other new drugs that are available. And as I said, the bronchodilators, and in addition, these are the drugs that are as a class that is used. Now, I can enumerate on the classes. The common beta-2 agonists, you must have learned from a long time, all the beta-2 agonists, starting with the short-acting broncho beta antagonists, like you have your salbutamol and all. But the newer ones, there are olodaterol and vinalterol. So these are the new ones there. And we have the long-acting. Yeah. So the long-acting is salmeterol and formoterol. The next group, if you would see, is the antimuscarinic drugs. And those are long-acting antimuscarinic agents, antagonists. That is, we have ipratropium and tiotropium. Coming down further to the methylxanthines, we have theophylline and etorphylline, and there is another newer drug there. But there is the most commonly used by the patients are derifylline, which is a combination of etorphylline and theophylline. So this is the common that is used. So these are the bronchodilators that are commonly used, and the other set of drugs that will be used according to a individualized therapy depending on the patient's symptoms. So it's very specific, and you have to watch out. The pharmacological therapy depends upon the individualization. So monitoring the drug and the effectiveness helps us in identifying which is suited for this patient. And the mainstay about this we have not mentioned is oxygen, long-term oxygen therapy. That is another. The drugs that have to be given in when we take a COAD is to be taken for a long time, and it's chronic. And at the same level it should be maintained. That is the crux in the treatment aim of COAD.
Right, ma'am. You did mention about the GOLD classification. Namita, if you can just elaborate on the GOLD classification of COPD.
Actually, basically, as you all know, GOLD classification is based in the management of COPD. So basically that contains 4 important aspects. One is regarding the airflow limitation. So then is regarding the symptoms. That's we can assess by MMRC grading, and then other comorbid factors, and also number of exacerbations. So based on that, we can divide it into A, B, E group. So in the A and B group, they are okay. Like there won't be any much exacerbations. Then MMRC grade will be less than 1. But in the group B, there will be MMRC grade more than 2, but there won't be much hospitalization. But in the E category, they'll be having more than 2 exacerbations in a month. Sometimes 1 or more hospitalizations also will be there. So the cornerstay in the gold classification regarding the management of COPD is bronchodilators.
Okay.
So like compared to the bronchial asthma, we'll be telling about inhaled corticosteroids. But the role of inhaled corticosteroids is very limited in COPD.
Right.
So the mainstay is long-acting bronchodilator, beta-2 agonist, as ma'am told, like formoterol then. So that is, we can use in A and B. Okay.
Right.
So when the symptoms are more, we can add LAMA also, long-acting muscarinic agents also.
Right.
That is depending upon another classifications there we have to look for the exacerbations as well as the dyspnea.
Okay.
So based upon that, we can add LAMA.
Okay.
So the inhaled corticosteroids comes into play only when there is an eosinophilic predominance, or when there is an asthma overlap.
Okay.
Or so that's why we are suppressing the inflammation.
Okay.
In that way only we are using inhaled corticosteroids. Okay. These are the pharmacological therapy that we are telling. Other non-pharmacological measures, that is the most important because one of the commonest reason is smoking. So we have to advise them regarding the smoking cessation, and also some like non-pharmacological physiotherapies are there. Strengthening exercise are there that we have to tell. And regarding the vaccination. And the other part is, it's a chronic disease. So the nutrition has to be taken care. The nutrition of the patient, that also has to be taken care. And then we have to manage the other comorbid illnesses. Like if diabetic, any other things, all those things also we have to take care. So these are the other things we have to take care. That is also mentioned in the gold management regimen. So then other like newer therapies, NIVs, then oxygen therapy, that and all we have to add depending upon the patient. And the cornerstay is, it's not a one-time disease. As a physician or as a pulmonologist, we have to follow up them. Suppose if I am admitting a patient and I'm starting on an oxygen, like that doesn't mean that he needs to continue on LTOT or continuous oxygen. I can reduce it depending upon the clinical symptoms. So that is in brief, sir.
Fine. Okay. Over to Dr. Nithya. Can you just elaborate on the workup for a patient with obstructive airway disease with specific focus on the role of PFT in the same?
So, PFT plays an important role in diagnosing these conditions. So, but they plays a different role in asthma and COPD. For COPD, it's one of the cornerstone of diagnosis. For COPD, we take a post-broncho, according to the GOLD guidelines, it's a post-bronchodilator FEV1 by FVC ratio of less than 0.7, which is diagnostic. And then we need a post-bronchodilator FEV1 value, which is used to classify the severity of the disease.
Okay.
And so this PFT, it plays a role not just in the diagnosis of COPD, but it is also used prognostically also. Because if it's a very low FEV1, it naturally indicates that a poorer prognosis for that. And this level of obstructions, depending on mild, moderate or severe, we usually classify it as post-bronchodilator. If it is more than 80%, it is mild obstruction. Between 50 to 80%, it's moderate. Between 30 to 50%, it's severe, and less than 30 is severe. So usually when it comes to less than 30% and all, it indicates a very bad prognosis.
Okay.
So that would influence your therapeutic decisions on whether you need what bronchodilator you'll be giving them, and those decisions and all. And that would also indicate the need for the rehabilitation. So suppose it's a highly dyspneic on the lower group of the lower part of the obstruction. So obviously we need to think about an early referral for a rehabilitation and other things for those patients.
Right.
And when we come to, it is not just a one-time PFT. We might have to repeat, because suppose the patient is not responding to the medicines you are giving,
Yeah.
then we will have to reconsider your diagnosis, because we are just because we say that there's a obstruction, it need not always be COPD. It could be a mixed disease also. Because there would be coexisting ILD, there would be RB-ILD like diseases. So suppose the patient is not responding to your usual line of management,
Okay.
we will have to reassess again. And those decisions also, a repeat PFT might play a role. And obviously, if you are going to look for a transplant evaluation and all, specifically there are transplant criteria which will say, yeah, this is the cutoff value which is not improving with a bronchodilator, where you are given treatment for 3 months and all, and in spite of that it's not improving, then obviously these values will help you in the transplant referrals also.
Okay.
And when it comes to asthma, though PFT is needed, we can rely on the clinical factors also, because here the clinical score, the symptom and the history also plays an important role.
Okay.
So suppose it's a severe asthma, you don't have to always do a PFT before giving a steroid. First you do it and make sure that the patient is stable. Try to make him off steroids and then do a PFT. And obviously for asthma also, we take a PFT value of FEV1 by FEC of less than 0.7 for the diagnosis. And then we go into the stepwise management of asthma.
Okay. By now, we reasonably understand that inhalers do play a major role in this management. Prince Madam, can you just once more just elaborate on the various mechanism of action of the inhalers and also the mode of delivery of these drugs?
This is a wonderful paradigm shift that happened way back in the 1980s that has made this disease and asthma more tolerable and acceptable. In fact, if you say you have asthma, marriage proposals were, off. So that's why this has made it a ordinary common disease, which is well accepted. So this came with the inhalational therapy. Now, in inhalational therapy, we have 4 bronchodilators as well as inhalational steroids. And the best would be to have steroid plus an inhalation that would keep it stable and preventing from further, it would augment and it would prevent further exacerbations. That is what has been advocated. So we have the drug can be in a powder solution, a powder with air, that is a dust, or a mist, that is a drug solution in moisture, in air. So like how we have the mist in November. So the drug can be given as a metered dose inhaler, but now we put a P in front of it, calling it the pressurized metered dose inhaler. And this would be given out through a stream of air or oxygen. A gas is put, either air or oxygen, or you could have an ultrasonic metered dose inhaler, which has a piezoelectric cell that keeps vibrating and pushes the drug through. So these are the 2 ways for putting. Or we have a dry powder inhaler. This is commonly given, but best is nebulizer. Nebulization is a wonderful technique by which the drug is given, and by this method you can give high quantities of drug. So and the best part about inhalational method is, of course, it is direct target delivery is given, better absorption, but there is least systemic absorption. So that cuts off the adverse effects, and with a small dose you can manage it. In fact, the metered dose inhalers and all, they are having, especially the pressurized ones have 50 to 200 doses in them. So this is a very good way of giving just hardly 100 microgram of salbutamol, if you were to say, as opposed to the times before 1980s where you had to eat 4 milligram of a tablet of salbutamol per day not knowing when your symptom is coming. This can be taken only when your symptoms of, so that's the paradigm shift that has encouraged. So this is, nebulization is a very good technique. In fact, you can give in the severe cases high doses of antibiotics too. So when we see the bronchodilators, how do they act? The beta blockers will be, beta agonists act by the increasing the cyclic AMP that relaxes the muscle. The M3 receptors are inhibited by the antimuscarinic drugs, and also we see that theophylline and all, the methylxanthines act through affecting the phosphodiesterase, and the new group of drugs are the PDE4 inhibitors like rolfumilast. These are the new avenues that we are looking at. But these drugs and the use of steroids. Steroids, you know the mechanism of action. So it is affecting lymphocytic, eosinophilic, infiltrations are reduced, the inflammatory mediator concentration in the sputum is also reduced, and so many aspects come into it to help. That is how you reduce the action goes. And our idea is again to get a stable COAD. It's basically getting a stable patient without reducing the progression of the disease and preventing exacerbation. That is our motto.
Okay, ma'am. Dambika, madam, what role does our sympathetic and parasympathetic nervous system play in this bronchodilation and constriction?
Now, actually, Princey Madam has discussed about that with the drugs. She was telling about beta-2 agonists and salbutamol drugs. Actually, sympathetic, they act through the beta-2 adrenergic receptors. That is how the sympathetics are acting, and they bring about bronchodilation by the adenylyl cyclase mechanism by increasing the CAMP. This was actually discussed with the drugs, the same thing here. And then when we see the parasympathetic action, it is through the M3 muscarinic receptors, as Madam has rightly said, and the neurotransmitter here is acetylcholine, and this acts through the IP3 DAG mechanism, and that is how it brings about the bronchoconstriction. And these nerve endings can be stimulated even by some irritants, noxious gases. All these things can stimulate the parasympathetic nerve endings, and that can also cause bronchoconstriction. I had told in the bronchial tone how the adjustment of the diameter of the airway is very important, and same thing here. The keyword is sympathetic causes bronchodilation by acting through beta-2 adrenergic receptors. That is why we use drugs in the favor. Beta-2 agonists are used to favor the bronchodilation, and the M3 muscarinic receptors are responsible for bringing about the parasympathetic action.
Okay. To Dr. Namita, during her discussion, Dr. Nitya did mention about the stepwise management in bronchial asthma. Can you just elaborate on that?
Yes, sir. That's why that is elaborated in the Dnia guidelines. It's a global initiative for the asthma management. So the cornerstay, what happened in the past and what is a significant difference in the present is, previously we were so used to use this short-acting beta-2 agonist. But now the paradigm has changed into inhaled corticosteroids. That has become the cornerstone stay in the bronchial asthma management. So that's also, we have to divide depending upon the symptomatology, whether it's a mild or mild persistent, moderate persistent or severe asthma. Depending upon the daytime symptoms and the nocturnal symptoms, we can classify. So based upon that, we can use certain medications. As ma'am told, there are some newer terminologies that has come into the Dnia guidelines in the management. One is, as you all know, it was previously there, controllers. So that we have to control the airway problems with some medications. That is the inhaled corticosteroids. And so now newer thing was anti-inflammatory agents. That's anti-inflammatory reliever therapy. That is a new add-on. One of the examples is again inhaled corticosteroids, and what ma'am mentioned was leukotriene receptor antagonist and the newer biologicals. That plays an important role in the anti-inflammation. And other thing is the reliever therapy. It's a rescue therapy. As and when the symptoms are coming, we can use. So based upon the symptoms, there are track 1 and track 2. So the track 1 and track 2, there is no comparison or not. The preferred thing is the track 1. We can follow the track 1. And we can also employ track 2 also. So I told you, mild symptoms, then persistent, moderate and severe. So depending upon the grade, it is classified into step 1, step 2, step 3 and step 4. So in the step 1 and step 2, we can use inhaled corticosteroids with the beta-2 agonist combination. Okay, so that we are generally prescribing with a formoterol and then budesonide or beclomethasone that we can use. But in the step 3 and step 4, the role of the same thing is there, but we have to increase the dose of inhaled corticosteroids into a medium dose or high dose. So even if with that it is not subsiding, the other roles comes into play, like biologicals. So that is a track 1. In the track 2 also the same thing, but there it was a long-acting beta agonist like formoterol. But in the track 2, they are telling about a short-acting beta-2 agonist. So almost the step 1, step 2, all these things are there, but the main difference is regarding the short-acting beta agonist. So in 2019 GINA guidelines and all, they were only focusing about SABA. But now that has been changed. So the newer guidelines are more in favor of inhaled corticosteroids, because the basic pathology, what is it? Because it's an inflammation and that is causing hyperreactive airway. So that we have to suppress. So that with the help of inhaled corticosteroids we can do. The commonly used ones, as ma'am said, it's budesonide, beclomethasone. So in the low dose inhaled corticosteroids, the budesonide content may be 200 to 400. Okay. But if in the high dose or medium, 400 to 800. Okay. So depending upon that, we can change. Suppose one patient is using like Workup inhaler or like formoterol with budesonide combination, 1 puff BD. Okay. But they are getting more symptoms. We can allot a step-up approach. Okay. We can make into a medium dose or high dose. We can just tell them they can use 2 puffs BD. So the same inhaler they can use, but we have approached like a step-up. The same thing, if there are no symptoms, they can keep a diary regarding the symptoms. If they are adhering to that drug and if their symptoms are getting better, we can do the step down approach also. We can revert back into 1 puff BD. And other drugs, like so many other drugs like leukotriene receptor antagonist, Montelukast, the benefit is still controversial. But we used to give in the clinical practice. But in the recommendation, it's not like mandatory to give. And also certain antibiotics like azithromycin. Ideally, like we have to give for few months. But nobody will be ready to take an antibiotic for few months. So that's all other add-on regimens. And the foremost thing is we have to counsel the patient how they are using. Suppose we have some classes regarding the communication skills. So the patients the inhalers are using in in a wrong way. So the medications won't be effective. So we have to ask them that how they are using, what protocol they are following, and then we have to move on a step-up approach. Otherwise, we have to continue on the same pattern.
Okay. So, Dr. Nithya, can you give an overview on the management of acute exacerbation of bronchial asthma and COPD?
For bronchial asthma and COPD, there are some basic difference in the management. Because one thing is, asthma is predominantly an inflammatory disease. Right. So steroids have a very big role to play in asthma. Okay. But that is not the case with COPD. Mm-hmm. And usually what is recommended, according to the guidelines, what they recommend is, for asthma, these patients, we should be giving a return asthma plan. And if it's a very difficult asthma and all, they should be monitoring the lung function at their home using a peak flow meter. Okay. And if they see a decrease in the peak expiratory flow of more than 20%, okay, they should be asked to increase the dose of either the SABA, that is short-acting beta agonist, or as in the guidelines recommended, it could be a LABA, that is formoterol with budesonide combination can be used, and it can be, if it's a budesonide formoterol combination, we can recommend them to use at least, if they are using twice daily, up to 8 times daily is also okay. But if it is not controlled only, we ask them to, the guidelines ask them to come to home. Right. But that is not, that won't work in the Indian setup. Yeah. So ultimately what is happening is they will be ending at a primary care. Right. So what we can do at the primary care? So here we need to assess what is the level of exacerbation. Mm-hmm. It could be a mild exacerbation, moderate exacerbation, or a severe exacerbation. Okay. So, and how do we classify that as a mild, moderate, or severe exacerbation? Mm-hmm. And so when a patient comes, look whether the patient is the level of consciousness.
Okay.
Or what is the level of respiratory distress?
Right.
What is the heart rate of the patient?
Right.
Whether he is able to complete a sentence or he is just saying in words. So by just talking to the patient, you will get an idea on how, even before touching the patient, you will get an idea on whether the patient is in a severe exacerbation. So if it's a mild exacerbation, that is, the respiratory rate is less than 24 per minute, the heart rate is less than 100 per minute,
Right.
and the patient is able to talk in phrases or sentences, yes, it's a mild exacerbation. You can manage in the ER, and that would be with an increase in the short-acting beta agonist. You can give short-acting beta agonist every 20 minutes,
Okay.
and it can continue till 1 hour. And at the same time, you can start with steroids. And if the oxygen saturation is less
Talking
than
about parenteral steroids.
yeah.
Inhalation steroids? Or?
No. What the guidelines usually recommend oral steroids only.
Okay.
But practically,
Yeah.
when they come to hospital, they won't be expecting us to give
Right.
an oral steroid. Obviously, when you are in a hospital, we are going to give an parenteral steroid itself. But the guidelines say that you can give an oral steroid. The oral prednisolone, some 50 mg is enough. That is what the guidelines say. So, an oxygen inhalation can also be given
Right.
if the saturation is less. But to maintain a saturation between 90 to 95%.
Right.
But that won't be the case with a severe exacerbation.
Okay.
That is, the patient is just able to talk in words. If the saturation is less than 90%, the respiratory rate is more than 30, or the heart rate is more than 120. In those cases, you just need to get this patient into an acute care facility,
Right.
because these are the patients who can even go in for an intubation with the plain asthma exacerbation.
Right.
We can't just think that asthma won't end up in intubation. Those also will end up in intubation
Right.
also. And once the patient is admitted, you will have to give it steroids, and till the acute care facility is available, we will have to maintain them with steroids as well as the short-acting beta agonist.
Right.
But when it comes to the case of COPD, steroids doesn't have that much of a role.
Okay.
Here, the first thing is short-acting beta agonist itself. Next comes the role of anticholinergics. Anticholinergics are not that important in case of asthma. Anticholinergics do have a role in asthma, but that is after phenotyping the asthma only, because there are certain phenotypes of asthma that is for the stable asthma.
Okay.
But in case of COPD, yes, definitely these anticholinergics do have a role. And here in COPD also, when it comes to an acute care phase, when it comes to an patient comes to an ER,
Okay.
here we have to differentiate between a severe exacerbation and a mild or a moderate exacerbation.
Okay.
So the mild or moderate exacerbation, we can go about with these things. But when it's a severe exacerbation, we'll have to do an ABG and decide on whether the patient is having hypoxemia, hypercapnia here, because in COPD, these patients have more chance for going for a hypercapnia and acidosis.
Right.
So obviously, when there's a hypercapnia and acidosis, the line of management will differ. Obviously, they will be requiring, depending on the level of consciousness, the pH levels, PCO2 levels, we will have to opt for either NIV or invasive ventilation,
Right.
and depending upon the hemodynamic status and all.
Right. Okay. And you did mention about NIV. Can you just elaborate on what does NIV and what role does it
Yeah.
plays in management of COPD?
NIV it's a mode of mechanical ventilation. So when we say mechanical ventilation, we will be always thinking that, yeah, there's a tube which is in your mouth. No, it's not always like that. Because you can give a non-invasive ventilation also.
Right.
Non-invasive ventilation means there's a small device and there would be a mask which is connected through the tube. And through that, you will give a positive airway pressure. And usually for the airway disease, what we give is a bi-level positive pressure.
Okay.
That is, you have an inspiratory pressure as well as an expiratory pressure.
Okay.
So what this does is, usually in COPD and all, there is a level of carbon dioxide retention, and this happens, one is due to the intrinsic COPD process, and
Right.
then there can be a respiratory muscle fatigue. And when there's respiratory muscle fatigue, effective carbon dioxide washout doesn't occur. So what this positive pressure does is, it will give a wash off of the carbon dioxide, that is by the inspiratory pressures,
Right.
and there can be an element of hypoxemia also.
Okay.
And this hypoxemia is corrected by the expiratory pressures. That gives a level of PEEP.
Okay.
So there are certain criteria for initiating on an NIV. So if the patient is having a carbon dioxide retention, that is in the ABG when there is a PCO2 of more than 45,
Right.
or if the pH is less than 7.35,
Right.
that is an indication for starting off on an NIV. But sometimes we might have to start on an NIV even when this criteria is not met,
Right.
because the patient would be compensating by taking more effort. They would be developing a respiratory muscle fatigue, and ultimately what will happen is if we wait for that pH to decrease, the patient would be ending up in analysis. So we don't have to wait for that.
Right.
In those circumstances also you can start off on an NIV. And another would be hypoxemia. Hypoxemia means it's not a type 2 respiratory failure, it's just type 1 respiratory failure. So for the type 1 respiratory failure, just plain oxygen is usually indicated.
Right.
But when it is a type 1 respiratory failure which is not responding to a usual oxygen supplementation,
Okay.
you can try off with NIV also.
Right. Okay. To Radhambika madam. One interesting thing which I found while really preparing this was the concept of appreciation of dyspnea. Can you just elaborate on the mechanism behind it?
Actually, when we say tachypnea, it is increase in the respiratory rate.
Right.
But dyspnea is difficulty in breathing, where you get an uncomfortable awareness of your own breath. Even when you do exercise, you get some amount of breathing, but we don't call it always dyspnea. Because it is uncomfortable awareness, which you see usually in cases of bronchial asthma, as you told, respiratory rate 30 per minute, all in exacerbations. So there all sometimes they have a difficulty in the expiration. So that time, that shortness of breath or the difficulty in breathing is called dyspnea. In COPD also we experience dyspnea. That time what happens is, I was telling about the normal physiology of respiration. There I told you that the diaphragm and the external intercostal muscles are mainly acting. Here what happens is accessory muscles of respiration also come into action. That is the sternocleidomastoids, scalene muscles, serratus anterior, all these, and it is a little difficult breathing, labored breathing. Usually a diaphragm, when it descends in normal respiration, it descends just 1 to 1.5 centimeter. But here in forced inspiration, it descends even 10 centimeters, 7 to 10 centimeters it descends. So it is a labored breathing. Work of breathing is increased in this case. And expiration, normally I told you there is no work done because it's a passive process but due to elastic recoil. But here what happens, when you say COPD, the elasticity is lost because alpha-1 antitrypsin deficiency in emphysema or the normal recoil of the lungs is not there. So there is a problem in the recoil. Here what the patient will use his own effort to breathe out. So the accessory muscles again of expiration, the abdominal muscles and the internal intercostal muscles, they are receiving the drive from the VRG. I told you ventral respiratory group of neurons in the medulla. So again these muscles are acting. So the patient experiences what is called dyspnea. And when you take a normal tidal volume, we say 500 ml is the normal tidal volume. If you multiply this normal tidal volume into the respiratory rate, that is 12 times usually, we get what is called the pulmonary ventilation. Pulmonary ventilation is about 6 liters per minute. And there's something called maximum voluntary ventilation. Maximum voluntary ventilation means how much maximum you can take in and give out in 1 minute. So that will come up to 120 or something like that. And there's something called breathing reserve. That is what is important here. That is why I'm telling. Breathing reserve, that means maximum voluntary ventilation minus the pulmonary ventilation. Suppose we are taking 120 and 6, it is 114. So that is normal actually, breathing reserve. But if breathing reserve is decreased, in some people, if the breathing reserve is decreased, those people will experience the dyspnea. And we can calculate another one parameter called dyspneic index. Dyspneic index is this MVV, maximum voluntary ventilation, minus the pulmonary ventilation divided by maximum voluntary ventilation into 100. So it is the percentage of the breathing reserve we are calculating. And here of the maximum voluntary ventilation, that is what we are calculating as dyspneic index. If it is below 60, the patient will experience dyspnea. So that is what is
Okay, ma'am.
dyspnea.
Principal Madam, we did mention about a lot of drugs during the discussion. So, can you just tell us what are the major side effects and adverse effects to look for when you're using these drugs?
Yeah. Side effects we have to contend with. So, when we talk about beta blockers, definitely you will know we will get muscle tremors, we will get palpitations because it's stimulation, right? Although it is beta 2 receptors agonist, but we have that. There is hyper responsiveness of the muscle, bronchial smooth muscle. There can be hyper responsiveness that can occur, and in some cases there can be there are occasions when they say it leads to hypoxia also with beta blockers, beta agonists. Next is methylxanthines, a whole load of adverse effects to contend with. There is nausea, diarrhea, vomiting because of PDE in action in the GI tract. Also, it has diuresis is also there. Plus, methylxanthines have this habit of stimulating the M2 receptors, preganglionic release of M2, and that will cause bronchoconstriction at times. Okay, at times. So it is you're causing acetylcholine release. Okay. So it can cause bronchoconstriction that way. Preganglionic M2 action, stimulation. So this is one rare thing, not common. Then if you see, next we were talking about, we came to inhalational steroids that we use, definitely local effects of dysphonia and all. And we have the systemic adverse effects right from all the hypoadrenal crisis and all that can occur. We know the adrenal steroidal angle. Next, I would take the all those that are affecting through the leukotrienes. So there we have Churg-Strauss syndrome. Churg-Strauss syndrome. This syndrome happens because of increased sensitivity. So this is one thing that happens, and so if you see, there are a lot of adverse effects happening. When you use LAMAs, it helps because in a way, there are some of the patients, especially in COPD, COAD, there are patients who have a raised vagal tone. And so when you give LAMAs, it has more action. That's why, as we said, you keep a diary when you're looking at the patient response, monitor the pharmacological drugs and how the patient is responding so that you can choose the right drug for the patient. So amongst the various adverse effects, we do find, but definitely the drugs are quite tolerable, but adverse effects do happen and manageable.
Okay. Dr. Nithya? So what are the usual complications you see in patients with long-standing bronchial asthma and COPD?
With the long-standing COPD, the commonest thing which we encounter is an exacerbation itself. Because if the patient is not compliant with the medicines, and obviously there would be other factors like infections, pollutions, exposures and all which are contributing to this. Then there can be some cases because of the some patients might be having this bulla and all. This bulla might be rupturing and they might end up in a pneumothorax. Okay. And when it's a long-standing COPD, at one stage they are going to develop a hypoxia. Okay. And this hypoxia, over the period of, if it's not attended properly and if we don't give a proper LTOT, oxygen therapy and all, these patients can develop a pulmonary artery hypertension, okay, which can go on to a call-pulmonate and a heart failure. Right. And in addition to this, there are other complications of COPD like cachexia, anemia, depression, and those things and all. So these are some things which we don't usually associate with COPD, but these are some things which will affect the quality of life of the patient. Right. And for asthma, it is commonly the exacerbation, but asthma patients also can have this like this pneumothorax and all.
Okay.
So, but asthma, rather than the other complications, it would be the asthma severity as such which is leading to complication. Because there would be cases of uncontrolled asthma, and there can be superarid fungal infection like asthma, ABPA, that is allergic bronchopulmonary aspergillosis. Those kind of conditions can be there. So where uncontrolled asthma is in itself is a complication, and that should prompt us to look for what is the reason for the uncontrolled. It can be from a simple non-adherence to either to the technique or to the medicines which are given, to something which is more complicated, like a very severe asthma.
Okay. And one last question to you. What's the role of pulmonary rehab, and also is there a role for vaccines in preventing it?
Yeah, there's a big role for vaccine, especially in case of COPD. Because as I said, in COPD, it's mostly infections which are coming as exacerbation. So if it's a person who is aged more than 65 years with a COPD, there's definitely an indication for vaccination. There's definitely indication for an annual influenza vaccine, as well as the pneumococcal vaccine. Pneumococcal vaccine, the current recommendation is PCV20. But PCV20 is not available in India. So what we do in India is give a dose of PCV13 first, followed by PCV23, PSV23 after 1 year. And in addition to that, what the gold guidelines recommend is RSV vaccination, Tdap vaccination, and varicella vaccination. These are also recommended for a COPD patient. And in addition to that, these patients should be rehabilitated. Because what happens in this COPD, mostly it's a progressive disease. And this, at one stage, these people would be confined to their home if we don't properly rehabilitate them. We have to, because of the dyspnea, they will say, yeah, I am feeling dyspneic, so I'm going to do it, I'm not going to do this. But we should encourage them to use the muscles. Otherwise, if they don't use, the muscle strength will decrease. And when the muscle strength decreases, obviously the dyspnea will increase. So they will quickly go from a gold A to a gold E COPD within a short span of time if we don't give a proper rehabilitation. So it is important to identify this patient, and by rehabilitation, it is not just an exercise training which we mean. We have the nutrition issues, the psychological issues, plus the exercise training. And exercise training, it is not just the respiratory muscle training which is important. The limb muscle training is also important, because if you see most of the COPD patients, they would be very cachexic. The muscle mass would be decreased, especially the lower limb mass. So if we focus on giving the endurance training as well as a strength training, along with the respiratory muscle training, they would be able to sustain a very good quality of life, and we would be able to prevent those long LTOT prescriptions and NIV prescriptions. At least we can delay those prescriptions. And at the same time, we need to give them psychological counseling. So all these things comes as a part of rehabilitation itself.
Madam. So the final round of questions. So what are the common questions for the MBBS students to expect from this topic? From an exam
Before I tell about the common questions, I just want the students to note one point. They should know the difference between the conducting zone and the respiratory zone, because that is very important in the physiology of respiration when we are talking about. The conducting zone is the first 16 generations. That is Wiebel's model. He has designed a model of the tracheobronchial tree. And the first 16 generations are just having dead space air. 150 ml. The remaining part only is the exchange zone. So they must know about that also. Tracheobronchial tree, the divisions, everything. Then the next thing is the mechanics of ventilation. We have not discussed in depth, but that is also an important way. How about the various movements, bucket handle, pump handle movements, all they would have heard. How the lung expansion occurs, how the dimensions increase. That is an important question we always ask in physiology. Then they should know about bronchial tone. Bronchial tone is very important. Then regulation of respiration, neural regulation as well as chemical regulation of respiration is very important. And then the bronchodilation, how it is occurring, bronchoconstriction, those mechanisms also they have to know. And dyspneic index short notes we usually ask.
Madam, questions from this topic? If you missed anything, please feel free to elaborate.
I was just, I mentioned, I forgot to mention in the adverse effects, LAMAs, they are antimuscarinic. So definitely 15% of dryness of mouth occurs in every of the patients, and definitely glaucoma can be precipitated, and so also urinary retention. So I didn't mention it because it goes with the territory. So as a student, you should be prepared for your pharmacology exam. Definitely a question can come in your long essay as a case of some asthma or a COAD, and the first part will be which are the drugs that can be given. Definitely, you don't even ask, even if they say enumerate or which drugs, you have to give it as a classification. So give the whole set of drugs, not only the bronchodilators, those that are affecting to steroids, those that you're using as affecting the inflammation, that is leukotriene, all that was mentioned. Also, you should mention, because COAD, we should also mention antitrypsin 1 augmentation, mucolytics, these are very important. The antitussives, all these also should be mentioned, because to make the answer complete. Then definitely a question on beta-2 agonists in therapy. This is a standard question. Then you may get ipratropium bromide as a question, a short note by itself, 5 mark. And there is also inhalational therapy. You know, it's just like for, it could be considered as a general pharmacology question, but it is there in any of them. This can be, these are the questions that come. Definitely, short note on Staphylococcus. I don't know, as you said, we don't know so much, but this is being widely prescribed. Any other person, Staphylococcus, Montelukast, so that comes as a question too. And xylitol is another drug that is in synthesis inhibitor that can come. So all of these can come as a short note, and you can get in the long essay also a case of asthma or COAD, and this is a definite necessity.
Amita, both from theoretical and clinical aspect.
So first of all, I think I will tell about the practical aspect, because as per the CBME guidelines, you can get anything as long case. So suppose you are getting a bronchial asthma case, you should be able to take a proper detailed history, and you should be able to differentiate it from a COPD with the history and the clinical features. So suppose if a patient, like if a patient, a COPD patient is having a bounding pulse, palmar erythema and asterisk 6. So these findings are, we are expected to get it from an MBBS student. But if suppose they are telling only bronchial asthma, and when the examiner is examining the patient, they are getting the diagnosis part is changed. So the approach is important. In a bronchial asthma or a like COPD, the bedside examination, they have to start from the basics, from the history, from the clinical features, then the differentiation, how you should do clinically. But I would tell in an MBBS graduate, the other PFTs and the other management aspects, they should know the basics, but I would suggest they should know the clinical aspect of bronchial asthma and COPD in the practical-wise examination, and the examination aspect you should be thorough. That is my suggestion. Right. And as per the theory, as ma'am said, like the physiology questions also come in general medicine, the pharmacology aspect also come in. But an essay can be like framed with the COPD. Okay. Suppose a 68-year-old male who's a chronic smoker, right, he's presenting to you in the ER, right, with altered sensorium, tachypnea. So when you are done an ABG, which is showing a respiratory acidosis with a PCO2 of 90. So what is your likely diagnosis? That is a essay. Right. So that way you have to train. So the initial questions, what is the likely diagnosis? So what is the initial management you can give? What is the likely investigations you want to give? And they can also ask about this GOLD and if in the asthma GINA. But like I would tell that as an undergraduate student, we won't expect that much guidelines to be written in a format. So they should know about bronchodilators, as ma'am said, some examples, some side effect, the mechanism of action, and also inhaled corticosteroids. So that aspect should will be considered.
Okay. Yeah, she did cover everything, right?
Yeah,
you have to
it's all.
No, right. Okay. So thank you all. I'm sure it was a very fruitful discussion, and there was a lot of learning points for all students. See you for the next episode. Thank you.